I'm curious, how many of you decided to come tonight because you were encouraged by the nonpartisanship announcement? Good. Great. How many of you came because you heard we were serving wine? Let's be honest, we're being nonpartisan tonight. Everything goes in here. Okay. In case you'd like to know, we changed our name from RAP, W-R-A-P, to RAP, R-A-P, because men actually wanted to join up with us women and help us put together these nonpartisan events, for which we are very, very grateful. We did actually consider citizens rising above partisanship, but the acronym is not pleasant enough. So we are leaving it at RAP, if that's all right with everybody. So for our first nonpartisan activity that we can all rally behind, if you are able, will you please stand and join me in the Pledge of Allegiance? I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Few housekeeping items. We do have some water in the back of the room, and the restrooms are immediately outside the door to your right from whence you came. We have sign-in sheets by the front door, and you're able to check whether or not you'd like to have notification about future forums, or if you'd like to even help us in the planning of future forums. We're kind of a raucous, disorganized group, so all the help would be very, very helpful. Also, we have a donation jar out there. We got really involved in planning this thing, got all organized, and realized we really didn't have any money. So we haven't told the applause of that yet, but we're not. We can pay that bill. Jeff may have to wait a day or two over there. But if you can help us with that, that would be great. If not, it's the old, a couple of fish and loaves of bread. Things will happen. It'll work. My name is Kathy Bartos. And I'm probably the only rap member that's going to identify myself right now. We're waiting to see how this evening turns out. So I got the right first. All right, in reference to the program, if you have any suggestions for how this could be improved or for future forum ideas or speakers, if you have a suggestion jar out front, please use those cards and the pencils and fill them in and let us know. Also, inside your program, we do have our email address. We'd love to hear from you. Again, we will take constructive, no name calling kinds of comments from you. So that would be great. And speaking of cards, we're going to be allowing each of our three speakers tonight to complete their presentation. We're leaving ample time for questions at the end. Given the size of this audience, and just so that we can control the voices in the room to make sure everyone can hear questions, you'll be asked to write them down on a card and pass them to the end of the aisle. We'll have people posted on the end, and they'll be collecting them. Here you can see Margaret Beer she's holding up her little basket. And they'll take those cards, and we will give them to our moderator, who will then read them. And that way, you know, there are always a few people who put this mic out there. We'll never get it back, so you know who you are. The cards, we're going to pass them out. If you didn't grab some on the way to the door, we'll make sure you all have enough cards for questions once we're ready to go. And now it's my pleasure to introduce our moderator for tonight. He's a great Carson City citizen. He's a wonderful guy. He's involved in many programs in our community. He was the editor of our Nevada Appeal for 10 years, and he's currently the director of the Nevada Press Association. So without further ado, I'm going to turn the microphone over to Barry Smith.
This is not the audience I expected when they said it was a rap group. But it's great to have you all here and wonderful. I'm going to take very little time, but because Kathy ran through most of the basic ground rules, I'm going to let you know who's got all the information, who our speakers are tonight. Dr. Susan Pintar. That's not mine. I know. I already shuffled her speech, so. Susan was born and raised in northern Nevada. She's one of 5 children, and her parents were public school teachers. And emphasized the importance of education. Dr. Pintar attended UNR, graduated from the University of Nevada School of Medicine in 1981. She completed a residency in pediatrics at Children's Hospital Medical Center in Oakland, then was in private pediatric practice for over 25 years, mainly here in Carson City. Her practice emphasized special needs pediatric patients. She also serves as medical director for Eagle Valley Children's Home, consults for Nevada Medicaid. She became the health officer for Carson City in 2009 and serves as chair of the Board of Health. She was recently asked to speak at the National Association of Local Boards of Health Conference in Atlanta, Georgia. Dr. Pintar has been involved in a number of professional organizations, including Chief of Staff at Carson Child Hospital, President of the Carson Douglas Medical Society, and CME Chair of the Nevada State Medical Association. She's a 30-year member of the American Academy of Pediatrics. And you may see her riding around town on her orange bicycle. She's proud to be part of such a bicycle-friendly and walkable community, and she always wears her helmet. Idea of the other two speakers that we're going to have, and I'll do their biographies when it comes their turn, but Dr. Pintar is going to lead us off. But as you can see, John Hager, or excuse me, it's going to be Stephen second, right? Stephen Weiner. And Stephen serves as a regional outreach specialist of the U.S. Department of Health and Human Services, Region 9. That's based in San Francisco and includes the states of Arizona, California, Hawaii, territories of American Samoa, Commonwealth of Northern America. It's a whole lot of places. Including one I had to look up, the Republic of Palau. Okay. All right. And in this role, Stephen ensures that close contact is maintained by the federal government with state, local, tribal, and territorial government officials on a wide range of health and social service issues. He also works extensively with external, non-governmental individuals and organizations. Health and Human Services has 10 regional offices that work actively to address the needs of communities and individuals through the HHS programs and policies. And previously, Steve worked for the U.S. Environmental Protection Agency's Office of International and Tribal Affairs in Washington, D.C. And then John Hager He became the first executive director of the Silver State Health Insurance Exchange in January of this year. Mr. Hager was appointed by unanimous vote of the Exchange Board in an open interview process because of his leadership skills, group insurance plan knowledge, and hands-on experience launching and operating a health insurance exchange. Prior to assuming that position with the exchange, Mr. Hager was the Chief Financial Officer for Nevada's Public Employees Benefits Program. As CFO, Mr. Hager was responsible for all aspects of the program's $476 million annual budget, which serves 72,000 state and local government employees retiring to dependents. He served in the U.S. Navy for 9 years as a pilot and aircraft commander of the P-3C Orion in Operations Enduring Freedom, Iraqi Freedom, and as an instructor pilot in the T-34C Turbo Mentor. Earned his master's in business administration from Texas A&M, Bachelor of Science in Physics from the U.S. Naval Academy. He lives in Carson City with his wife and 2 children. So, thank you. I really appreciate it. We have a lot of expertise here among these 3 panelists. I think it's going to be very interesting. And as Kathy mentioned, you have cards. I don't know that they're going to answer all your questions, but if they do, we're going to try and sort through them and find out things that we haven't heard. And apparently this is the first in 27 forums on the Affordable Care Act. But we're going to cover a lot of ground, and I thank you again all for coming.
I have a mic.
No, you need a microphone.
I have a mic. I have 2 mics. Okay, let's see if I have 3 hands. Well, thank you for the introduction. I am reminded that I don't like being reminded how long I've been doing this job. As a pediatrician, I think subliminally I probably chose that job so I could hang around kids all day and pretend I was their age, but that hasn't worked very well. I want to begin the presentation by giving a bit of an overview of the Affordable Care Act. We're going to refer to it tonight as the Affordable Care Act or the ACA, even though, as you are aware, the whole name of it is Patient Protection and Affordable Care Act. And I think that one of the things, especially from a physician perspective, is that it does contain a lot of patient protection actions within it. However, we'll call it the ACA or the Affordable Care or the CARE Act, something along those lines. As you recall, it was passed by both Congress, by both houses of Congress and signed into law back in 2010. Some of the provisions were on hold until quite recently due to legal challenges, and I think that that's why, because it has been given, much of the bill has been given the go-ahead, that's why the interest is starting to peak. So since it's been upheld by the Supreme Court, now is really the time to familiarize ourselves with what it does and also what it does not include. Now, the first slide is the 10 titles. For those of you familiar with how Congress passes law, yeah, I know. And my disclaimer here is I'm not an attorney, I'm not a judge. I can read, like all of you can, so we can read the law. I am related to attorneys, one of my daughters, so don't throw too many pickles in. And my brother, and anyway. But so how these are organized is that they have the title of the act, and then the actual titles are the different sections. Now, why aren't they called sections, I don't know, but we're just going to go with it. And so there are different titles, and within the titles are sections, and of course under there are subsections, and then there's numbers and letters. And those of you who are English teachers are all going, yes, I finally hit it. But the bill itself runs about 1,000 pages. Did I read the whole thing? No, I did not. Will I? I probably will at some point, but not all in one sitting. The table of contents I printed out, it's only 20 pages. And all it tells you is what's in the act. So yeah, as soon as I told you it's only 20 pages, reading Affordable Care Act, cross it off your list. But having said that, I do want you to read the parts of it that are interesting to you, and hopefully our presentation tonight will help clarify some of those sections. And as much as possible, I and Steve and John will try to mention, all right, if we're talking about things that are in Title I or Title VIII or whatever. If you do have questions about where it is, I do have some reference material with me, so I can tell you what that looks like. It's probably in Title V. So if you need to know that, hopefully we can look that up for you. The best resource that I found is what Steve refers to as his website, although I think he had a little help with it, is healthcare.gov, and maybe you got the handout that was left in the front that is healthcare.gov. On that website, you can actually read the law in its entirety, in its original language. You can also read the, I can't remember what when they will make an explanation in understandable language. And that both of those things occur there, so that you know that it's easy to see. So a little bit about some of these titles. Title I, quality, affordable health care for all Americans. We're going to spend some time on, not me so much as the gentleman. And that really, because it's the lead off, is where people have a lot of questions. The role of public programs is really where Mr. Hager will come in. I'm going to talk quite a bit about what's contained in Title III, which is called Improving the Quality and Efficiency of Healthcare. Title IV, Prevention of Chronic Disease and Improving Public Health. I am the public health officer after all. And Title V, which is the healthcare workforce. Titles 6, 7, 8, 9, and 10, I think gentlemen will touch a little bit on some of Title IX. Title VII, we're pretty much going to ignore. And that's because right now, Title VII is on hold. Secretary Sebelius sent a letter to Congress in October, I think it was, basically saying that the bill, the way it was passed, was unworkable, that they had investigated and they weren't going to be able to work on that unless there were some changes made to the legislation. And so at this point, as far as I know, the Congress has said, okay, well, we'll see what we can do about that. So Title VII will not be discussed. So we know that the ACA is a big, complicated piece of legislation, and how do we begin to understand it? I will admit that I freely, borrowed this slide in a form at a recent conference I attended, and while it started out looking difficult, the more I looked at it, and I'm going to hopefully guide you through it, it helped me, and I think it will help you make more sense of the Affordable Care Act. There are, in this interpretation, there's two groups of actions that the Affordable Care Act deals with. Insurance reforms, which are on the left side of your screen, and delivery reforms, which are on the right. I'm going to talk a little bit, starting with those insurance reforms, and I will pretty much end at prevention benefits. And the gentleman will be discussing some of the topics under delivery reforms. But we will cross over a little bit. I found this, as I said, a real useful way to kind of divide the different pieces of legislation contained within this larger bill. So, under more people, how does this bill affect us? Well, the biggest one is insurance exchanges. All right, we're going to defer that. John talked about that. Guaranteed issue of coverage. That means that you cannot be denied for health care insurance coverage with a pre-existing condition. Plain and simple. Many of you have experienced this when trying to purchase insurance for yourself or your loved one. That you, for example, my child, for example, has a history of ear infections. And so when you underwriter sends your insurance back, says, we will cover everything except anything having to do with the ear. And you're like, well, what the heck do I want this insurance for except to treat my child's ear infection? Well, those are the kinds of things that that are now not allowed to be done by the insurance companies. It also prohibits insurance companies from rescinding coverage based on technical mistakes. And I don't know how many of you have encountered that, but I encountered it not infrequently in my practice, that a family would fill out a form incorrectly or not put in the Social Security number of their new baby because they didn't know it yet. And then 3 months later get the form back and says, oh, we didn't cover your child because you didn't include all the information. Well, those sorts of things are going to be considered technical mistakes. I have one, to me it was a heart-wrenching story, a child who was a healthy baby, but about 3 months of age, got sick, needed to be in the hospital for 3 or 4 days. In the course of the hospitalization, the hospital investigated or wanted to know what the family's insurance was, and the mother said, well, they're insured through the company that I work for. The hospital called the company, and they said, no, we've never heard of that child. Well, the mother had called her HR person on a number of occasions. That HR person had neglected to sign the child up. Because of that technical mistake, the baby's hospitalization the cost of that fell completely on the parents. So those are the kinds of, shall we call them technical mistakes that should be rectified. Now, will it be perfect? No. But there's lots of examples that all of us in the profession can say where people have been turned down for coverage or their coverage has been delayed because of technical mistakes or a pre-existing condition. And these are a lot, the provisions I'm talking about right now are within Title I and a little bit within Title III as well. The Act also allows parents and guardians to purchase insurance for their dependents under the age of 26, which I would say in my case is very lucky. I have 3 children. They've gone to college. They've actually gotten jobs. my son in particular, it took a while, but you know how boys are. So he gets a job, and the job has absolutely no benefits. And he's 24 years old, he's graduated from college, he's got a job, but he has no benefits. Well, he does, 24-year-olds do some high-risk activities. I don't know if you've noticed that. And I'm thinking to myself, I think Chris could back me up on that one, okay? I'm thinking, somebody runs him over in his bicycle, and it ain't going to be him that pays the bill, it's going to be the mama that pays the bill. So I'm going to cover him under my health insurance plan, and I will sleep easier. He won't get a care. I don't know too many kids under 25 who don't think that they are invincible still. But, from the standpoint of a parent, I felt better knowing that he had some health insurance in case he needed it. The other big thing that is that I have had the non-uncommon experience of a grandparent wanting to insure a grandchild. And until this legislation changed that, you could not. You could only insure a direct dependent. So, some of you may have noticed that teenagers have babies. And so, as the responsible parent of that teenager, many grandparents want to provide health insurance coverage for those children, and until now they could not. So this makes a better system. I will tell you that the Medicaid program will consider a woman independent after the age of 18, but teenagers before the age of 18, their family income is determined on their parents' income. So those are women who don't qualify for Medicaid very often. I think there are a number of provisions under the more people, meaning more people will be covered, that are very useful for lots of us. Under better coverage, in the next little section, under this legislation, there are a number of provisions, and most of them are in Title III, in case you want to know. The first one I'll mention is cost of Medicare rate review. A lot of the provisions have to do with keeping track of costs of payments to hospitals and physicians and other providers. There's lots of healthcare providers that this affects.
physicians, dentists, optometrists, physical therapists, occupational therapists, home health care workers, hospitals, extended care facilities, lots and lots. I'll just go on with it. And so they all are very interested in how this is going to affect their rates, their reimbursement. No doctor that I know of thinks that Medicare pays them too much. If you have one of those doctors, hang on to her. But as you probably are aware, there are some specialty physicians that are paid a lot more for doing a procedure than your primary care physician might be for, diagnosing your depression and arranging for follow-up and all of those sorts of things. So, you may know this, but a primary care physician under Medicare gets paid a little bit over $50 per visit. When I was operating my practice, and this is a bit out of date because I closed my big practice in 2009, it cost me about $40 in overhead for that visit. So I flirted with just asking for $10 bills from everybody, but that didn't go over real well. Compare that with, I'll pick on radiologists because I'm married to one. That, for one, they don't do anything except look at pictures all day. I mean, they come so I'm so tired. All right, so the radiologist does arteriogram on you, pokes you in the groin, sends a piece of plastic up into your heart, shoots some dye in there, takes pictures of you. And that procedure takes about an hour and a half. And I don't know what they get reimbursed, but I know it's a heck of a lot more than if your primary care physician spent an hour and a half of pretty quality time with you. Well, so those are inequalities that need to be addressed. From a physician standpoint, I think everybody would like the bar to raise. From a practical standpoint, is that going to happen? Probably not. But I think those of us in primary care, and I would say that all physicians believe that primary care is undervalued. And so from that perspective, the provisions within the Affordable Care Act are aimed at leveling that particular payment playing field. Now, there will also be some adjustments made based on where that physician practices. If I practice in Hawaii, not Hawaii, Hawaii, because it's a medically underserved area, I will get a little bit bumped up because it costs more for me to get supplies and everything else to my primary care practice. Carson City is not a rural designation, and many of you know that, but rural is, and I'm going to defer to you. My understanding of a rural definition is less than 50,000, and you have to be, I think it's over 50 miles from a qualified medical center. So while Carson Hospital is a very good medical center, it doesn't offer every service you need, but still, because we're not more than 50 miles away, we don't qualify. Anyway, having said that, there will be some adjustments for those different parts of the country that are medically underserved, and Nevada has a lot of medically underserved territory. Another part of this cost review will be provisions that hospitals and skilled nursing facilities participate in what are termed value-based purchasing programs. Those are reimbursing for costs plus a specified markup, if you will. Some of you may have encountered the $15 aspirin. If you look at an urgent care bill or a hospital bill.
$5 Kleenex.
A $5 Kleenex, although I went to Logs and that's, but yeah, and so what hospitals do in order to keep themselves revenue neutral is that they have to add costs where they can. And it's not anything I blame them for. If they don't get paid for this particular service, you have to find somewhere to recoup it. But what the act is saying is that if if Dr. Pater, if you pay $50 for a dose of MMR, we'll pay you $55.
we're not going to pay you $85. So that's hopefully going to help there. Now, the next one, prescription drugs, I think is one that lots of us here in the audience are interested in. Donut hole, anybody get that? Lots of people have. Those of you who purchased Medicare Part D, which is the drug coverage, may have found that once you get to a certain amount of out-of-pocket expenses, the reimbursement for your medication essentially disappears. I'm not going to go into the details of it, but then you end up having to pay more out of pocket, that's the hole. And then on the other side of the hole, then reimbursement for those medications reappears. Well, the legislation within the Affordable Care Act initially started to take place this past year, 2011. And seniors now get a 50% discount on brand name drugs when they reach that hole. Now notice it's brand name drugs. So if you need a brand name drug and it costs $500 a month, which is, I hate to say, but that's probably not uncommon, you will get, you would have to pay $250 of that instead of the whole $500 so that you can start swimming across the donut hole. Then over the next 10 years, some additional measures are going to be put into place to eliminate the donut hole altogether. So that's really, from the prescription drug standpoint, there are some other things in there. There's going to be a little bit more emphasis on generics, on helping people understand when generics are appropriate, when they're not appropriate, helping physicians understand that too. You may know that physicians are very heavily marketed by drug companies. They come to our office, they bring my friend office lady gifts, they bring her candy and things like that, and so she lets them come in and talk to me. We have to check out that. The idea is that drug companies would like me to prescribe their brand name drug. And sometimes their brand name drug really is the only appropriate thing that will help. But oftentimes it's not. And so generics are typically cheaper, not always though, so don't be fooled that they're always cheaper. But anyway, the point being that the Affordable Care Act does have quite a few provisions that help with the cost, lest I say exorbitant cost of medications in America. I want to go on now to the thing that to me is pretty interesting, which are the preventative services. And there's a few slides here, and I'll go over them in a little bit of detail, but not a lot. There are 16 specified covered preventive services for adults. These are the first few. The first one, an abdominal aortic aneurysm. Your aorta is that big artery that comes off of your heart, goes down the middle of your abdomen, and then splits off to your legs. But in the meanwhile, it branches back to your heart to give it blood, and then to all of the organs in your body. An aortic aneurysm is when that big artery develops a weak spot and it kind of balloons out, like a balloon that you've blown up once, and it comes back and it never quite regains its size. Well, what this specifies is there will be a one-time screening allowed for men. Now, I have to say, I'm going to put my plug in here for evidence-based medicine. The evidence-based medicine has not found this to be a useful screening test for women. It's only a useful screening test for men who have ever smoked. And so, we women will get our due later on, I'll show you. But anyway, I want, when you say the word abdominal aortic aneurysm, it's like, what the heck is that and why would I be screened for it? But it will be a covered benefit. Alcohol misuse screening and counseling. Tremendous public health issue, especially in Nevada, alcohol and smoking. But if you went to your physician and said, I feel like I have a problem with alcohol, what can you do for me? Basically, your physician really couldn't do anything official. Or they could do something official and not get reimbursed for it. Okay. So I think this is a good first step. Is it comprehensive? No, but it's a first step. It will cover aspirin use for men and women, blood pressure, cholesterol screening, colorectal screening, which is the newer version of the test. Those of you who have taken home the card, and they tell you to put a certain bodily product on the card. There's a more advanced test that is now recommended that you don't have to not eat meat and all this kind of stuff. So anyway, that's the colorectal they're talking about. Depression, another big issue in Nevada. We have very high rates of suicide. We have very high rates of mental health issues in the state and in the county. And so even raising the idea that we can do depression screening and that it's part of routine, normal health care, to me is a big deal. Diet counseling for adults at higher risk for chronic disease. You may or may not be aware that any nutritional services I should say it better, nutritional services are very rarely covered under health insurance. Meaning, if you are obese, if you have type 2 diabetes as a result of being overweight, the biggest thing is, all right, lose some weight. Well, help me do that. Your health insurance isn't going to do that. Well, now, at least, again, it kind of opens the door. The diet counseling for adults at higher risk is included as a preventive benefit. HIV screening for all adults at higher risk, obesity screening, and immunizations, my favorite topic. I'm a pediatrician. I have seen in my miserable lifetime, I have seen diseases disappear because of immunizations. One of my mother's favorite stories is having pertussis, whooping cough, when she was 6 years old. It's 75 years later. The woman still remembers how scared she was having whooping cough and thinking she was going to die. She's like the poster child for the whooping cough vaccine. And many people, I think because vaccines work well and we don't see those diseases, we forget about them. We think, oh, they're not so important anymore. Nobody's going to get those. Well, we are. And so the immunizations for adults are, to me, a wonderful part of this bill. And if you do have questions about what these are or when you should get them or how, I'll be glad to address that. Okay, ladies, here we go. 22 cover preventive services for women, including pregnant women. And this hit the press earlier this month because these became effective August 11th, 1st? What are those days? Okay. And I'm not going to go through a whole lot of that, except I'll explain some of these. Bacteriuria is bacteria or germs in your pee. BRCA counseling is the genetic test for women. There's 2 genes, BRCA1 and BRCA2, that increase your risk of developing breast cancer. So that this preventative services gives you an idea. The idea is to give you information about whether you should have the test or not. Some people know they're at risk and choose not to have the test. So it's not making you have the test. It's making sure that you have the information so that you can make an informed decision about having the test. Breast cancer mammography screenings every 1 to 2 years for women over 40. You have no idea how tough this was to get. Is mammography perfect? No, it's not. But it's the best thing that we have. And so, including screening tests, covering mammography to me is a big, big deal. These are other screening tests and other interventions, I guess I should say. The one, again, another one that's sort of near and dear to my heart is the domestic and interpersonal violence screening. Nevada leads the country in number of deaths from men killing women. That's not something we need to be proud of. Again, from a public health perspective, we have a big problem with domestic violence. And I'm not just saying men against women. There's also women against men domestic violence. again, raising the issue, making this part of the healthcare conversation for you and your primary care doctor is huge. To me, it's huge. Because these are not things that you typically would say, I'm very uncomfortable with the way my son is treating me. And so, does it go as far as I'd like it to go? No, it doesn't. But again, it opens the conversation so that these sorts of things get on the table, to use that phrase. Children. Some of you have children. Lots of you have children. Alcohol and drug use assessment for adolescents. Again, these are things, and I'm going back to the other, these are things that your primary care doctor would love to cover in your checkups. A couple of constraints, time and money. So we're hopefully, by including these, and as I say, making them part of the conversation, they'll get done. And that's what the children's tests are as well. Again, depression appears on here. I would have to defer to Susan, but I think that we are number 1 or 2 in the country for adolescents and suicide. We're pretty high. Fluoride. Carson City is not fluoridated. It's not likely it will be fluoridated, but fluoride in the water is a very effective supplement, a very effective way of reducing dental decay. And so in those places that don't have fluoride in the water, now this would be a covered benefit if their parents choose to. Here's something that I think will be interesting to many of us. The preventive, I fuss at myself. Preventative is not a word. Preventive is a word. Feel free to correct me if I say it wrong. Preventive services available to seniors, those who are 65 years old and older. The annual wellness visit has been in effect for 5 years, 6 years, not a whole lot. It used to be that when you became eligible for Medicare, you just started seeing a doctor. Now, and many of you have been used to being told, well, I'd like to see you every 3 years for a routine checkup. And with Medicare, until this, there was no such thing as a routine checkup. So many doctors, and I won't name names, but I practice with them, who are internists, would have to emphasize a diagnosis in order to get a checkup covered for their patients. They would like to go over all of those, has anything changed in your life from a physical standpoint, from an emotional standpoint, any birth, death, all those sorts of things that affect your life. But if you came in and your diagnosis was high blood pressure, theoretically you couldn't get those services. So a few years ago, there was introduced a welcome to Medicare visit, but you only got one your whole lifetime. Now you get to have. Oops, go back. You get to have a well check. No, that's the kid word. Checkup. We call it well check. Once a year if you desire, where basically you can go in to your physician and get a comprehensive history of physical and some of the screening tests if they haven't been done before, or if you need another one. So that those can now be done for those of you who are Medicare beneficiaries. Again, I'm going to go back to tobacco use cessation counseling. Big deal in Nevada. We have 25% of Nevadans smoked in 2009. The last figure I saw is down to 22%. But that is lovely, but it's not zero. I would like it to be zero. But that 22% are engaging in a very high-risk behavior. Is it going to kill you tomorrow? No, probably not, but it is going to kill you at some point. either that or it's going to make you darn sick and suffer with it. So putting tobacco use cessation counseling in the conversation to me is important. For seniors, these are the screenings that are covered. Bone mass measurement is screening for osteoporosis, brittle bone, loss of calcium in the bones. I can give you details. I'm not going to, but I can. You know, there are certain limits on like how old, how many, those sorts of things for all of these screening tests. Cervical cancer, diabetes screening, flu shot, pneumonia shot, hepatitis B shot. Hepatitis B is something that a lot of us over 50 don't talk about or don't think about. Hepatitis B is considered, or has been considered, a teenager, young adult disease. It is primarily sexually transmitted. The problem with hepatitis B is that you can get it as a teenager, young adult, and it will stay in your body in what's called a latent form for years and years and years, and then activate itself later. And so hepatitis B, in a certain number of cases, does become liver cancer. So having said that, hepatitis B as an immunization to me is a very important part of it. So, I'm going to go back, and more back. There we are. So that is the prevention benefits, or many of the prevention benefits. I want to finish up by saying that, as you can imagine, some of these are controversial. The bill does have some pretty strict guidelines that the tests that are and are not included will be what's called evidence-based. It can't just be because you want it or your doctor wants it. It has to be that there has to be some sound medical evidence to back it up. And there is actually one of the big provisions is forming a National Prevention Strategy Council that will examine this kind of evidence and provide it to practitioners to say, this test is worthwhile, this test is not. There are a few other things, though, that I was asked to address about this. And from a physician's perspective, just like all of us here in the audience, some of us are thinking this is a great bill, some of us are saying it's a horrible bill. Physicians are the same way. But there are some certain questions that physicians and healthcare delivery systems are asking that maybe the general public might not. The first one is, are there enough of us? Are there enough primary care doctors? And the answer is no, there's not. So if there's a lot more people being covered, who's going to see them? Well, I don't think the answer is let's not cover them because then they don't have to get seen. I think the answer is somewhat addressed in the bill that we will try to train more healthcare workers. And it's healthcare workers of all stripes, to use that analogy. There has been one estimate that I read, and I don't have any verification of it, that if the jobs within this bill come to fruition, it could contribute something like $5.6 billion to the economy in employment. So that there would be more nurses, more doctors, more respiratory therapists, more home health aides, more hospital administrators, all of those sorts of things. I don't have any backup for that except an article that I read. But, the question is, as a primary care doctor, is there enough of me to go around? The answer is no, there's not. But hopefully the bill has provisions to help make that. One of the problems might be the unintended consequence of primary care doctors or people in medical school saying, I'm not going to be a primary care doctor. I might get paid a little bit more, but I'm going to have this huge number of people to see. So hopefully that unintended consequence doesn't happen, but it may. Number two, will we be paid fairly? I told you there's not a whole lot of doctors who think they're overpaid by Medicare. And so far, the cuts that have been proposed have been delayed But, you know, it remains to be seen how that will happen. The third question is, how will this affect hospitals? Now, many people feel, and it's been borne out in the medical literature, that if people have access to care, non-hospital, they will try to access that care and stay out of the hospital. But there are many people who don't have health insurance who go to the hospital for a couple reasons. One, they don't know anybody else. Two, they know they're not going to be handed a bill on the way out that says pay this right now. And so the idea is that if we make primary care more accessible to more people, that the load on the hospitals as far as ER and those other visits that are not necessarily ER appropriate should go down. That's the hope. And then the big one that doctors always talk about is, what is the regulatory burden going to be? Medicare has a lot of paperwork, and it's a lot of paperwork to put, you know, for physicians to fill out, for staff to fill out, for you guys to fill out. What changes is that going to help? So I know that there are some members of the organized medicine who are opposed to some of the provisions. I know that some that who are in favor of it. Many have concerns about governmental regulation of private enterprise medical practice, and I think that those are all legitimate concerns. I do have to say, though, as a primary care practitioner, now a public health practitioner, that overall I'm pretty pleased with the things, especially the prevention benefits that are covered, and I really think that we will have a positive outcome eventually.
Stephen is from the Office of the Regional Director, U.S. Department of Health and Human Services.
Thanks, Ed. Good evening, Carson City. How are you? Thanks for having me. This is really a great opportunity. I'm really excited to be here. My name is Stephen Weiner, and I'm here to talk to you about the healthcare law, the Affordable Care Act, and what it means to you, your family, and your community. I'd like to thank RAP for having me, Judy Plume and Kathy. Just want to say thank you to them. And it's an honor to be up here with your Silver State Health Insurance Exchange Director, Executive Director John Hager, and thank you to good Dr. Pintar for giving us an amazing presentation. The good news is she stole most of my material, so I shouldn't be too long and keep me here. But I really want to give you guys an applause. Thank you so much for being here. Clap for yourselves because you're here. Thank you so much. And I think that says a lot because in a time when we have access to information on the internet and we can form our own opinions by listening to TV, it's really good for you to hear from people who are involved and know what's going on. And you want to know how this is going to affect you, and I think it's great that you're here, so thank you for being here. The slideshow here. So I work for the Office of the Regional Director. Okay, his name is Herb Schultz. Some of you might have met him or come across him before. And he is a presidential appointee. He is a political appointee. I am a career civil servant. So whatever happens in the next election, I'm still going to be in the same spot I'm in now. My job is not to change your mind about who you're going to vote for or what you think of this bill or how you feel. My job is to get you this information. So that's what I do, and as you heard, Region 9 covers a huge swath of land, and we have 50 million people to take care of. It's a lot of people. We're the biggest region, the way it's divided up by HHS, and I am the regional outreach specialist, so it's my job to come in here, give you information, keep you informed, and help you decide what you think of things and how things can help you. But really, I'm a resource. At the end of this presentation, I'll give you my email address, my phone number, my direct line, and that's what we're here for. We're here for the people. We're here to hear from you. We have questions about your health care. We have questions about anything in health and human services, and we are a humongous government agency. We have all the acronyms. We have CDC, the Center for Disease Control. We have FDA, the Food and Drug Administration. We have CMS, which is the Center for Medicare and Medicaid Services, and 10 others. So we have a huge bailiwick under us, and it's my job to sort of quarterback when a call comes in and decide that should go to and who should be there to help you. So you're here to educate yourself. As the good doctor mentioned, healthcare.gov is the main website that I would direct your attention to. It's just something that, if you need information, if you've got a specific question on something that's on your mind, how does this affect my kids? How does it affect me if I'm a senior? How does this affect me if I'm a minority? Whatever you need, it's going to be there. Healthcare.gov. Just punch in the search engine and it'll pop up for you. It's very useful. So I think a good way to frame this, and I'll do it a little bit different than Dr. Pintar. The first question we have is, a lot of people say, well, why do we need this? Why do we have to have this affordable care? Why did this happen? And the answer is that for a long time, our system operated where we had a health insurance market that worked really well for insurance companies, but not necessarily so well for us, the people, or you and your families making decisions about your health care. Insurers could pick and choose who they wanted to be part of their system. They could block out people, as Dr. Pintar mentioned as well, and in total, we had 50 million Americans who were uninsured. And many more had insurance plans that they didn't understand. Or if the employer decided not to carry the plan, what would they do? And so it left many Americans feeling kind of queasy, kind of uneasy about their health care coverage because it wasn't necessarily in their hands. It was the insurance company telling you, here's what you get, and that's it. And there wasn't so much individual freedom, and I think that was a big problem. So, as you heard, President signed the bill, March 2010 happened. And the way I'm going to parse it out, a little bit different, like I said, rather than the 10 pillars, is that there's 4 main things I want you to take away with you tonight about what the bill is going to accomplish and how it's going to help you. The first is better access to care. The second are consumer protections, many of which are taking place today. And a lot of people say, well, this law doesn't take effect until January 1, 2014. Not true. Many of these provisions have already taken place and are affecting all of us. The third part of it is that this will strengthen Medicare. And that was a big reason that the bill was put through. And the fourth, and probably the most important for a lot of us, is that it makes healthcare more affordable. So I'll try to talk about a little bit about each of these. We'd like to say, for our office, this is really something that, yes, it is a federal law, but it's going to be implemented by the state of Nevada and your local communities, and this is where the work goes on. This is where the doctors are. This happens in your community, at clinics, at hospitals, in other places, community health centers that you have here in Nevada. So here's kind of looking at the numbers, the approximations. So we had a problem, 50 million people uninsured. So with this law, we're hoping that 32 million more of those people will become insured by 2014. And of those 32 million, 29 will be through the insurance exchanges, which I'll leave John to talk about. And my numbers might be a little fuzzy, John, so maybe you can help me out with those. One of the provisions of the law that you've probably heard a lot in the press was about the individual mandate. So, but I want to make this clear. For the vast majority of Americans who have health insurance, nothing changes with this law. This is mainly to take care of people who were uninsured before. In order to bring those 50 million people who did not have insurance, we have these new provisions. And the individual mandate, what is that? It is a mandate. It is something that is a mandatory requirement for citizens to have insurance. There are particular exemptions, but for the most part, that's the plan. If we have more people with insurance, we're going to be able to lower the cost for everybody else. These next 2 slides relate to Medicaid. And one of the things Dr. Pintar was touching on was the Medicaid payments. And I just wanted to kind of echo that, in that some doctors, like my sister, don't take Medicaid patients because she says, you know what, it's not worth it. There's too much headache, it's too difficult, and I don't get the reimbursement rate. Well, in the next 2 years, the federal government will be paying that rate of Medicare for doctors who are taking Medicaid patients. So it ups the rate of the Medicaid patients to where the Medicare is. Does that make sense? Okay. In addition, the federal government will pay 100% of the cost to states covering newly eligible individuals for the first 3 years of expansion. Now, what does that mean? This is the big provision in the ACA, the Medicaid expansion, which was the only part of the Affordable Care Act which was not upheld by the Supreme Court. This is where the decision came back, and it went back to the states. The states have the option to do this, okay? But here's the deal. In the first 3 years, the federal government has told the states, we will pick up the tab. We will pay for the Medicaid expansion, okay? So the states are left paying nothing for the first 3 years. And thereafter, the federal government pays 90%. So the state is only paying 10% for the expansion. So states will have a decision to make. You know, they can either take the money on the table or they won't. This is a slide in relation to getting people kind of expanding access to folks in Medicaid. So right now, let's say this is just saying that 14,484 for one person. And these numbers are the poverty line and things like that. They're very ambiguous. But the point of it is that money's being, more people are being allowed into the system because 133% of that federal poverty level, now those people are going to be able to be part of Medicaid, not just up to 100%. Excuse me if I'm going kind of fast. I want to get to the questions because I know there's a lot of them, and I took a lot of time preparing to answer a lot of questions. Dr. Pentar mentioned the provisions of people under 26. Does anybody have kids under 26? No kids under 26?
Great-grandkids under 26.
This is a good story. This is one of the most popular provisions of the Act, in that the kids, not only can you have them insured while they live under your roof, even if they're gone, if they're away from you, your insurance will still cover them. So that's an important thing, and for someone like myself, I didn't have insurance from ages 24 to 27. I was young, I had a job that didn't have insurance, and I thought, oh, what do I need insurance for? And my mom would yell at me, because she would say, well, you know, if something bad happens to you, it's going to fall on us to pay for you. So, of course, she did insurance about my mom. But now, people under 26 are covered by, the parents' insurance, which is a good thing. And just looking for, our country so far and what's going on in Nevada, so far, 3.1 million young people have gained coverage nationwide because of this, okay? And we're only talking since March 2010. We're only a few years into this. And as of the end of the year last year, 33,000 young adults in Nevada have gained insurance coverage. So that's 33,000 people that have insurance that would not have been insured without the new law in Nevada. Another thing, I'm going to kind of skip around to. A lot of times we talk about these provisions and things like that, but we all know that health insurance wasn't the only obstacle to care. Too often you call your doctor up and you hear that the next appointment was in 4 months, and that wasn't going to work for you because you were sick now, or you had a rash, or whatever. You needed to see your doctor sooner than that. Or you go in there, you only get 10 minutes with your doctor, and then they had to move on to the next patient. I think we've all been through that experience when we've had to visit the doctor. That's why the healthcare law also invested in training and placing thousands of new doctors nationwide by providing bonus payments to primary care doctors. And again, Dr. Pinchar mentioned that, and that's different from specialty doctors. The law is also creating and expanding health centers across the country, and this will help you spend more time with your doctor. So looking at new community health centers, the Affordable Care Act is providing $11 billion over the next 5 years. And $9.5 billion of this money will go into new construction for new centers, so more patients can be seen. The additional $1.5 billion will be used to retrofit and fix old buildings that need repair. And this will nearly double from 19 to 38 million patients that can be seen in community health centers. And looking at Nevada, there's 27 existing community health centers here, and so far, and this doesn't include a recent grant, Nevada's received $4.2 million. This slide is very similar to Dr. Pentar, so I think I'll kind of breeze through it. But as you can see, there are other preventative services now that are no copay, don't have to pay anything. And we know that getting these kind of screenings are key to keeping you healthy, preventative, getting ahead of the game before something bad happens, making sure you have a way to gauge your health as you go along. And a lot of times people had a decision to make. Did they spend that $50 copay to see if they were healthy, or did they spend it on groceries or something else? And so it's a good thing. It's good for people. And Dr. Pinchar really hit on how the law keeps women healthy. And as of August 1st, those provisions took place. And so now, women won't have to make that decision if they need to choose between a copay or feeding their families, same kind of thing. This is a big deal. This affects half our population, and it's important to have these things that you don't feel like you're obligated to go pay out of pocket for. And so now you don't. So these things are already going on. I'm going to leave most of the exchange stuff to John. I just wanted to go over real briefly. They must be operational by January 1st, 2014. And there'll be a coordinated effort between the state exchange Medicaid programs, and the CHIP, which is the Children's Health Insurance Program. And again, I'll leave this to John. In addition, we were looking at, I'll just read some of these to you because these were things that happened in the past. Newborn denied health insurance coverage days after a life-saving heart surgery. Low health insurance cap leave patients stranded. Well-point routinely targets breast cancer victims for recession. All those things, gone. It can't happen anymore. The insurance companies can't do that anymore. And that's because the Affordable Care Act has a patient's bill of rights. So now it's legal for insurance companies to deny coverage to children because they have a pre-existing condition like asthma or diabetes. It's illegal for insurance companies to put a lifetime cap on how much care they will pay for you if you get sick. And it's legal for insurance companies to cancel your coverage when you get sick by finding a mistake in your paperwork, as Dr. Carson mentioned. And under the old system, no one got a worse deal than the 129 million Americans that had pre-existing conditions. When buying coverage on their own, insurance companies could hike the rates, and they can't do that anymore. I'll move on into Medicare. So over the next 10 years, the law will save the average person on Medicare $3,500. And people with Medicare who have the highest prescription drug cost, that saving goes up to $12,300. In 2012, the average premium for prescription drug plans went down compared to 2011. The deductible for doctor's coverage decreased. Standard premium for doctor's coverage was lower than projected. And the average Medicare Advantage premiums in 2012 were lower than in 2011. And again, I won't go over these because I think the doctor did a good job of telling you what you get out of Medicare in the preventative services and the free annual wellness business. Specifically though, looking at Nevada, in terms of covering preventive services with no deductible or copay, in 2011, over 230,000 people with Medicare in Nevada received free preventive services. And in the first 7 months of this year, 113,000 people received free preventive services. And because of the law, 54 million Americans with private health insurance gained preventive services, including almost 500,000 in Nevada. Approximately 47 million women will now get guaranteed access to additional preventive services without cost sharing for policies, including over 390,000 in Nevada. In terms of making prescription drugs available and affordable to seniors, since the law was enacted, Nevada residents with Medicare saved a total of over 24 million on prescription drugs, just in Nevada. In the first 7 months of this year, 8,484 people with Medicare received a 50% discount on the coverage of brand name prescription drugs when they hit the deductible. This discount has resulted in average savings of $590 per person in Nevada who's on Medicare, and a total savings of over $5 million this year. And I think a few of the things that people don't know about the law is about the deficit, and you hear a lot of back and forth about what's going on. According to the Independent Congressional Budget Office, the reform is paid for in the next 10 years.
That's not true. It just issued, it's $1.8 trillion.
Quiet, let it finish.
He is finished. He's been quiet since he got up there.
Get out of here.
I haven't seen that.
Well, you look around.
So the CEO estimates that in the first 10 years, it will reduce the federal deficits by $100 billion. You
Not true.
guys have to show me what you're looking at. And it's supposed to go down by...
The National Budget Office refute what you just said.
I just took this off the website yesterday.
I'm sorry.
Let him finish, will you?
Questions at the end.
Then you can ask the
We can
question.
have some discussion.
So going back to some of the abuses of insurance companies, there's now a new law, it's the 80-20 rule. So basically what this says is, in the past when you paid $1, over 40% or 40 cents on the dollar would go to extraneous overhead, CEO bonus pay, not things that weren't involved in your health care. Now with the Affordable Care Act, we have what's called the 80-20 rule, which means 80% of the money that we spend on health care must go to health care improvements or care. And if they don't, the insurance companies must repay the money. I'm curious, has anyone received a rebate check? How much was it?
$152.
So as of August 1st, 12.8 million Americans have received more than $1.1 billion in rebates from insurance companies. This is an average of $151 per household. And in Nevada, it's even higher, $180. So, just look at some of these things, as far as increases in insurance company spikes and things like that. Those are the kind of things that are going to go away because of the Affordable Care Act. Before, the insurance companies could raise your premiums by double digits without justification. Today, insurance companies must publicly justify their actions if they want to raise the premiums by more than 10%. And states have more power to go on them. Small business are the backbone of our economy. 2 out of 3 new jobs are created by small businesses. And the Affordable Care Act has a small business tax credit to help businesses help pay for insurance. So the small business, same thing, doesn't have to make the decision between hiring workers and providing health care insurance. They can do that. So who qualifies for this? Businesses and nonprofits with 25 or fewer full-time employees and average wages of $50,000 or less. So this is a little summary slide. Insurance companies can no longer deny coverage to children with pre-existing conditions. An additional 2.5 million young adults have health insurance. Millions more Americans have access to free preventative care. Insurance companies are more accountable to consumers. And thousands of new doctors and nurses around the country. I encourage you to go take a look at healthcare.gov, as well as the Congressional Budget Office's website, to learn more about the healthcare law. This is my contact information for both my boss, Herb Schultz, the regional director, and me. If you've got questions, please feel free to call, email me. I'll do my best to get back to you. I think at this time, I'll turn it over to Barry.
So you have to admire Steve for coming in here, be brave to bring them to come into situations like this and provide that kind of information. There's always somebody that doesn't agree with it. Fortunately for me, I'm just a government bureaucrat that works for the state of Nevada. So my job is to implement the health insurance exchange. My job is to interpret what the feds have provided for us, and so every now and then we chide the feds for all the regulations that they're putting on us. But again, my job is simply to implement. So I tried to provide just how it's going to affect Nevadans. A little bit about myself. I'm a former pilot. As an instructor pilot, I flew a T-34 front seat, back seat. So I typically sat in the back seat and you couldn't get out of the plane. I mean, you're flying and there's hardly enough room for your elbows. And if you drank too much water, you had to go to the restroom, but you had a parachute on and a life preserver on, and your strap, and so you have to unbuckle your seatbelt and unbuckle your parachute and unbuckle your life preserver and unzip, and really hope and pray that you had a good student in the front flying the plane while you're doing all that. Unfortunately for you, you don't have the luxury of being able to do that right here. So if you have to go to the restroom, we've been at it for a while, I won't be offended if you get up and go to the restroom. So feel free to leave, come back, it's okay, not a big deal. So we've talked a lot about the acronyms CMS, HHS, CHIP, and so I work for the Silver State Health Insurance Exchange. Our acronym is SHICS. Please try to say it correctly. It is not a 4-letter word, it's a 5-letter word, so we're okay. And I've been on the job since January, so if I make a mistake, you know, I'm the new guy, so what do I know? I'm going to talk a little bit about what a health insurance exchange is, purchasing coverage on the exchange, the tax credits, monthly premium, tax penalties, qualified health plans, individual shop exchange eligibility. That SHOP stands for Small Employer, let's see, Small Business Health Options Program. I should know that by now. It's an exchange for small employers. And I will probably skip the board and advisory committees because we'll be pretty bored by that point. Sorry, I had to say that pun. So, what is a health insurance exchange? I'm going to walk back and forth to keep the camera guys a little busy here. A health insurance exchange is basically like an Expedia. It's a marketplace for health insurance. So it's one place where you can go and look at all the products that are out there to purchase health insurance. And it's a complicated process. Now, it's hopefully complicated for us and simple for you. We're going to make it as simple as possible, and we've got a pretty good vendor working with us. The idea is you get a side-by-side comparison of all the different health plan options that are out there. You can see the premiums, deductibles, co-insurance, co-pays. You can look and find what drugs are covered by that particular health plan, what the doctors are on those health plans. So you can filter out the ones that you don't want because, you know, my doctor's not on that plan. My drug for this chronic condition isn't on this plan, so here are my 2 or 3 plans. And there will also be a premium calculator or an out-of-pocket calculator. You know, I go to the doctor 4 times a year, I have a specialist visit or 2 specialist visits, I got a surgery coming up, and it'll create kind of an estimate. Now, it's not perfect. There are a lot of diagnosis codes. Anybody here, ICD-9, ICD-10 codes? Dr. Pintar has. Yes, and so I think there's, I don't know, 10,000 codes, and ICD-10 is going to make 100,000 of them. There's no way we can make it perfect, but we're going to try and make it as simple as possible. So it's an organized commercial health insurance marketplace that will let you compare plans and hopefully choose a plan and enroll in a plan. Additionally, if your income falls between 100% and 400% of the federal poverty level, then you will be eligible for subsidized coverage. And so I'll get to that a little bit. Steve talked about the eligibility for Medicaid being optional. And so far at this point, we don't know if the state of Nevada will decide to expand Medicaid or not, if it will expand it to a midpoint or what have you. So at this point, the law is written so that you can have insurance, you can get subsidized insurance under the exchange down to 100% of the federal poverty level. Okay, so whether or not Medicaid goes from there up to 133 or 138% remains to be seen. But if you don't qualify for Medicaid, you can at least get that coverage down to 100%. And I'll go over what the costs are a little bit later. There's no wrong door. You go into a welfare Medicaid system, and you need insurance, it will switch you over to the business operation solution, to the exchange. If you go into the exchange system and it says, you know what, you're actually eligible for Medicaid or for CHIP for your children, then you can do that too. So no matter which way you go, you'll get to the place that you need to get the right coverage. And of course, it's a source of information on carrier plan and performance quality. We have to make sure that there are processes in place to make sure we have certified, qualified plans that we're selling on the exchange. So basically, for the shopping experience, you're going to enter some demographic data because we need to know if you qualify for a subsidy. We need to know your age, zip code, income, and if you're Native American. There are different rules for Native Americans. That information will go into our system, go into an eligibility rules engine, and will be spit out to the federal data hub. That federal data hub will say, yes, Susie Smith says that she is who she says she is, and this is what the income is that we have on her. And there'll be other ways to validate some of that information. It will spit out the advanced premium tax credit for your Medicaid eligibility or CHIP. So, the federal poverty levels, now this is based on 2012 data. In 2014, it will probably go up a little bit, but generally this is pretty close. It goes up a percent or 2. It's pretty close. So if you're an individual making $11,170, you are at 100% of the federal poverty level. You're at that level. If you make $44,680, then you're at 400% of the federal poverty level. So what that means is, if your income as an individual is anywhere in between those levels, you will get a subsidy through the exchange. And it's even more complicated on how that's calculated, but the end result is fairly simple. So typically we like to point out family of 4 making $23,000 up to $92,200 would qualify for a subsidy. It just turns out that about 50% of Nevadans are in those levels between 100% and 400%. 25% are below and 25% are above. So that is roughly half of Nevadans will get a subsidy through the exchange. Now, keep in mind you have to go through the exchange to get a subsidy, number one. And number two, I have to also point out that the exchange is only for individuals below the age of 65. Because if you're 65 and older, you get coverage through Medicare. So just want to make sure that's clear. So based on your income, that will determine what the amount is that you pay under what we call the second lowest silver plan, just to make it more complicated because we like to do that. And I'll get to the silver, what that means later. But basically we take a base plan and we say, all right, it costs $100 for an individual. Just pretend, probably a lot more than that, but just pretend just to be easy here, it's going to cost $100. So for an individual that makes 100% of the federal poverty level, they are going to provide an advanced premium tax credit equal to $91.38. So, $81.38, excuse me. So that the amount that person pays on a monthly basis is $18.62. If it's an individual 400% of the federal poverty level, well, if we said it was $100, they wouldn't get anything. It would just be free coverage. It would cost $100. But let's go back and say the premium was $400. So that $100 example is bad. So $400 premium, this person at 100% of the federal poverty level, they would get $381.38. This person would get, it looks like $46.68 or something like that. So they would get the subsidy that's needed to hit that amount. So if there's somebody in this room that's making $92,200 and they have a family of 4, if this were in place right now, their premium for their family of 4 would be $729.92. Now, I'm not going to say whether that's affordable or not. That's up to the individual to determine whether or not that is affordable. But it's likely a lot less than it would be otherwise. So, it's a little bit more, obviously, at the 400% level. For individuals that are only making 100% of the federal poverty level, you can see how much they would get out of this and how little their premiums would be. Now that's on the premium side. There are also cost-sharing reductions on the deductible side that will allow you to pay less out-of-pocket costs later. I know, very complicated. And again, if you go on to our system, when this is up and running October 1st of next year, it will be made a lot more simple for you. You'll be able to see exactly what your coverage is. So, can't really talk about the premiums unless you also know about the tax penalty. So if you are an individual, the tax penalty is 1% of your annual income if you don't get coverage, or $95, whichever is greater. And the $285, the maximum for a family, it's a family of 3, so $285. Again, it's the greater of that $285 or 1%. So, and then it increases by 2016 to $695 for an individual, $2,085 for a family of 3, and 2.5% of income, the greater of those two items. Also, employers with more than 50 employees must offer affordable minimum essential coverage. And I believe affordability is based off of 9.5% of income. Is that right? Yeah, so if your coverage costs more than 9.5% of your total annual income, then it's deemed unaffordable and you can go to the exchange to get coverage. If your premium is 9.5% or less of your annual income, then you have to get you don't get a subsidy for the exchange, you would have to take your employer's coverage. And the penalty that the employer pays if they don't offer coverage is no more than 2,000 times the number of full-time employees minus 30. So if you have 55 employees, subtract 30 from, if you don't offer coverage, subtract 30 from that, your total number of people that you are penalized for is at 25, that 55 minus 30 is 25 times 2,000, so the maximum amount that you can be penalized is 2,000 times $25. So again, selecting a health plan, and that's for small employers, not for the individuals. For selecting a health plan, again, you'll be able to compare health plans, search by doctor, prescriptions, hospital, basically providers. Select a health plan based on the cost provided, and then select other products, for instance, dental, vision. We might be able to offer additional products later on. I'm not sure about that yet. And then obviously enroll. So we talked a little bit about a silver plan. And basically what we try to do is we're mimicking the Olympics here, except for we added a medal at platinum. So you've got bronze, silver, gold, and platinum, and basically it means that the higher you go, if you get a platinum plan, your cost sharing, the amount that you pay out of pocket is going to be much less than it would be if you got a bronze plan. Bronze plans, the actuarial evaluations are showing at about $3,000 to $4,000 deductible. Silver is about $2,000, and again, these are rough estimates. Actuaries do this, calculation in their heads, and come out with their abacus and figure out that somehow the average person will pay about $2,000 into the silver plan. Gold plan, you're looking at closer to $500 to $1,000 in your deductibles, and platinum are closer to no deductible, $200 deductible, and then there's that's basically it. So that we won't make it any more complicated than we really have to, right? The plans have to be certified and accredited. They have to be offered inside and outside the exchange, so you can get the exact same product outside the exchange as you can inside the exchange. That's very important to know for those of you that make more than 400% of the federal poverty level, because we have to charge, I have costs, my staff, we have to pay my staff, we have to pay rent, we have consultants to kind of understand this whole thing because it's complicated, I think you can see. And so to pay for that, we have to charge a fee to the carriers. Therefore, it may be that, that coverage for the qualified health plans may be more expensive than a non-qualified health plan outside the exchange. So for those that make more money than 400% that don't get that subsidy that I was talking about, it might be less expensive to go outside the exchange. Now, for those of you that make between 100% to 400% of the federal poverty level, for that 50% of the VATs, it would be less expensive to go to the exchange because you would get a subsidy, the advanced premium tax credit from the federal government. So I talked about the advanced premium tax credit is based on the second cheapest silver plan, right? If you want to buy a gold plan, you can do that, but the difference in the cost between the second lowest silver plan and that gold plan, you would pay 100% of that. So you still get the subsidy that you would have regardless of which plan you choose, but you can buy a more expensive plan. And let's say you have a chronic condition, you have to go to the doctor more often, you want low out-of-pocket costs, so you're going to pay a higher premium, you're willing to do that. It could be that a 27-year-old doesn't think that they're going to ever die or ever get sick, and so they're going to take a bronze plan or a catastrophic plan. They would still get the subsidy for the silver level, but they would pay less than they would at that silver level because the cost for a bronze plan is less than the cost for a silver plan. Sort of makes sense a little bit? Yeah. I know, and I'm talking really fast because I'm already 18 minutes, well, I was 10 minutes overdue before I started, so. Okay, to be eligible for the exchange, you need to be lawfully present in the U.S. and a resident of Nevada. If you are a resident of California, go to the California exchange. Resident of Arizona, go to the Arizona exchange. Sorry, that's just the rules. You cannot be eligible for Medicaid or Medicare. As we said, you have to be under age 65. And I believe there are some individuals that are eligible for Medicare that are under 65 as well for certain disabilities, so that could throw a kink into things a little bit as well. You cannot be offered employer-sponsored insurance that I said was affordable. Oh, there's the answer that I was confused about, the 9.5%. And meets the minimum essential coverage that the actuarial value of 60%, that's that bronze plan, that 60% level is bronze. And again, subsidies are available between 100% and 400% of the federal poverty level. For the small employers, anybody own a business in here, small employers? Okay, for all of you folks, your employees will be eligible to go on the exchange. Basically, you would go in there, say, here are my employees, I want coverage, you make some decisions, and as long as you have 50 or fewer full-time employees. The committees, I'm not sure if the board has made this decision yet, but the committees have recommended to the board that we don't expand to 100 employees until 2016, until it's required by the Affordable Care Act. So in 2016, if you have a business with 51 to 100 employees, at that point you'll be able to get your coverage on the shop exchange. And then finally, the state has the option to expand it to large employers in 2017. If that happens, we'll have to see. I'm not sure. We talked about tax credits for employers with fewer than 25 employees if the firm's average wage is less than $50,000. So as a small employer, you have the option to choose all carriers and all plans. Basically, you say, I want my employees to be able to choose any plan on the exchange, on the small business exchange. And so the employee would see this option. They would see all plans, all carriers, all tiers. Or you can say, you know what, I'm going to limit it. I'm going to limit it just to the silver tier. I want them to have the option of going between carriers because there's different networks and they'll be able to choose different networks. But I'm going to limit what I pay, so I'm just going to offer just the silver plan. Or I want to offer really rich benefits to attract employees, so I'm going to offer a platinum tier for everybody. And then the carriers will be able to provide packages. Basically, if you're a small employer now, you go to a carrier, and typically they say, all right, you've got the option of choosing plans A, B, and C, or plans D, E, and F for your employees. And this kind of mimics what we have going on today. So various options for the employer to choose. This, what you see here, is kind of what the employees would see once you've made those decisions as an employer. And the rest of this is just governance and board stuff that you probably really don't care about, how we make the policies and everything. What I would invite you to do, just to speed things up, is go to exchange.nb.gov. That has a whole bunch of information. It has our strategic plan. It has our committees. We have 5 committees that make the policy decisions or make the recommendations to the board. Then the board makes the decision. We have regularly publicly noticed meetings. Has anybody been part of a publicly noticed meeting, putting it together? So you have your 3-day notice requirement and all the documents you got to put out on the website for everybody to see, and you got to send notifications out. We've had 31 of those in the last 8 months, so quite busy. So all of those are on the website to see. You can actually listen or view them online. You can look at the transcripts. If that hangar guy didn't know what the hell he was talking about, you can go online and get the real scoop from there. So with that, I think I'm going to stop there. And are we opening up to questions?
That was a lot to absorb. But if we do have time to get to the questions now, and one of them that's come up quite a bit is whether the costs of the subsidies and what's being spent on this Health Care Act, is that going to reduce the benefits from Medicare? Can you answer that?
Ask that question again.
Well, I think, thanks for the question, whoever asked it. I think from both my presentation and Dr. Panchar's presentation, you saw that the services that are being provided, if you have Medicare, all the additional benefits that you are getting. I mean, isn't that already sort of money in your pocket as far as what you would have been spending under the old system? You would have been paying for those services. So you have not understand the question. I think
again, the question is, does it take funds away from Medicare?
No, I think this is a lot of, there's been a lot of misinformation, and there's been a lot of things about healthcare laws that aren't necessarily accurate. I'd say under the law, I can't really speak for the administration, I'm not a political appointee, but I'm just talking about the facts of the law. The ARP has confirmed that efforts to protect and strengthen the guaranteed benefits seniors have earned, and Medicare cost growth has gone down. The life of the Medicare trust fund has been extended. And instead of cutting benefits for the seniors, this bill has found billions in savings and has, again, extended the life of the Medicare fund. So I'm not quite sure where a lot of the stats and figures are coming from for these questions and answers, but as far as what the Affordable Care Act is supposed to do, is projected to do, this should not be a grand issue.
Another question, and I don't know, excuse me, you're deep enough into this, John, that you can say whether the subsidies, the benefits, when the question is, will the savings from cuts to insurance and drug companies just be passed along to the consumers by the insurance and drug companies? Won't they just raise their prices?
I can answer that a little bit, and I'm certainly not the expert, but a big part of the council that's being for is to review rates. And I think on one of the slides we talk about cost review. As some of you have already experienced, you may have received a rebate from your insurance company. That legislation already went into effect, but if they don't spend at least 80%, in many cases 85% of their premium dollar on direct care costs, they have to give it back to you. And so I can't say that it's completely in effect at this point, but I think it should be. I don't think they can pass on those costs.
Yeah, my understanding is that the medical loss ratio cap is 80% for small, for individual small group, and it's 85% for large group. So they, Dr. Pincher was correct. They need to pay 80% of your premium, the premium that you pay. 80% of that has to go to health coverage, or for large groups, 85% has to go to health coverage. If they don't, they have to rebate you the check. The carriers are very interested, from what I understand, in getting it exactly right. Obviously, they want to maximize that 20 or 15%, but they don't want to have to pay the administrative cost of sending a check out. So it's in their benefit to make sure that that premium doesn't go any higher than what it needs to. As far as expenses to carriers, yeah, if there's an expense to a carrier, it's got to be reflected in the premium because they have to be able to stay in business. Otherwise, they got to shut their doors. So you want to have insurance. They're offering insurance, and unfortunately, you have to pay for that insurance. So if there is a cost, if there is a tax or what have you, that amount is going into that premium that you will pay, or the advanced premium tax credit will pay.
Thank you. This one, it was covered a little bit, but it's something I don't understand either. It's the penalty for the people who do not obtain health insurance. How that works, how many people do we expect will still be unable to afford health insurance and will fall through the cracks? Want to jump on that one?
I think a lot of these things are, approximations and we'll wait to see. But for example, in Massachusetts, which a lot of this law is modeled after, less than 1% of people chose to opt out. As for the penalty cost, I think John had it up there. The first year, it'll be $95 for an individual. For a family, it's ×3, so that's $285. The next year thereafter, in 2015, that 95 goes up to $325. Okay, this is again for an individual. In the next year, in 2016, it'll be $695. So it is an exponential raise as far as the penalty. Perfect. And so yeah, because the family is just ×3. Thank you.
I don't understand how do they know? Where does this come up?
That number?
No, I mean, at what point do you find out? The government, no, you don't have insurance, you're going to be penalized.
Yes, the IRS will know. They will find you.
Described a little bit about what's in the act for training nurses, doctors. Can you describe more of how that is going to work? And the question here says, training advanced practice registered nurses who will manage federally run health care clinics. Currently, the APRN works under the licensing physician. Will this law allow ARPNs to be independent practitioners? Do you know that?
Yeah. And the short answer to that is no, because state law always supersedes what an advanced practice nurse or a physician assistant can do. The law has provisions for training funds for physicians, both MDs and DOs, doctors of osteopathy, for nurse practitioners, which are RNs who have an advanced degree with some prescribing practices, for physician assistants who have that same level of prescribing practices. And it also has training funds for a variety of other medically related services. So, I mean, for respiratory therapists, occupational therapists, speech therapists. So it's not exclusive for there. One of the bottlenecks, as it were, is that right now there aren't enough training, postgraduate training places called residencies for primary care physicians, and that will expand that. To answer the other question is, advanced practice nurses or physician's assistants always have to practice with a supervising physician. Many of you have seen APNs and physician's assistants here in this community. I couldn't live without my APN. But she always had to practice under my license with my direct supervision. And there's nothing in the law that I saw that changes that. There are some minor tweaks to that, or minor differences for public health clinics. Public health clinics and federal public health clinics have, the nurses have more discretion in practice in one respect, but they have more oversight in the other. So if you have other questions, I'll be glad to answer that afterwards.
Thank you. I think if I understand this question, this is a good question that I'm not sure. This might go to the health exchange again, but it's, does the law address the discrepancy in charges between different insurance companies and individuals? Will the charges for medical services be equal for all parties? I think this question is actually good. The charges for medical services.
So insurance companies have contracts with each provider. And sometimes insurance companies have a standard contract for all their providers, and sometimes insurance companies have a different contract for each provider. But it's different for each insurance company. So the reimbursement rate that you and the insurance company pays the family care doctor or the specialist or the hospital is different depending on who you are insured with, and it's different depending on where you go. So if you go to a hospital, you and the insurance company might pay $10,000 for a relatively simple surgery, and if you go to the local outpatient facility, that cost might only be $6,000. Keep in mind that every time you go to the doctor, you or the insurance company is paying for that. Now, obviously, you don't want to pay for it, and so if you have a high out-of-pocket cost, you're going to try to not pay for that as much as possible, and not go to the doctor as much as possible. Realize that it's not necessarily good that you don't go to the doctor when you need it, which is why we have the preventive services now, so you keep going to the doctor. But also when the insurance company pays the cost of your doctor visit, that amount has to be put back into the rates that they charge you the next year. So keep that in mind. Every time you go to a service that you don't need, it costs the insurance company money, which will, in the long run, affect the cost of the amount that you pay in premiums. But I don't think that there's anything in this law that standardizes the rates that are charged to by providers to the carriers. That again is a contractual issue.
Well, actually, it's an antitrust. No, it's an antitrust issue. I can charge anything I darn well want, and I can ask you to pay it. But if I have a contract with an insurance company that says, for this particular kind of office visit, I agree to accept $50 as reimbursement, I can write $2,087 on my bill of what you charge, but I have agreed by contract to accept $50 for payment there. So the antitrust is you can't price fix as a provider of that service. I'm not supposed to talk to Dr. X about what he charges for the same procedure that I do.
Here's an interesting question. Will members of Congress be required to have similar insurance?
So, under the plan, federal employees like myself, civil servants, no. My plan will stay exactly the same as the one I have now. Members of Congress, yes, they will be interfaced into the exchange. That was part of the law.
That's kind of surprising, isn't it? This is something I don't know about, so this asks about who's affected by 3.8% real estate tax, and why is this in the healthcare law?
Yes, I had to dig this one up. So I can read the full-on explanation, but what I can tell you is that it will only affect a very tiny percentage. Here's how it works. First of all, only those with incomes over 200 grand a year. That eliminates something. Or $250,000 for married couples filed jointly will be subject to the tax. And even for those who have such high incomes, the tax still won't apply to the first $250,000 in profits from the sale of the personal residence, or for the first $500,000 in the case of married couples selling their home. That is there. Why is the tax there? It's part of the law.
On the exchange. Now, this chart shows how much you would pay as an individual on the exchange. But if you recall, the affordability percentage was at 9.5% for your employer. So if your employer provides coverage, so let's say that you earn $20,000. Okay, so I think that's somewhere around 133% of the federal poverty level. Carson City's median income is $52,000. Let's say $50,000. Let's keep them kind of close. So 9.5% of 50,000 is what? 4,750, right? So if divide that by 12, so we're looking at about $400 a month. So if your employer offers coverage for $400 a month or lower, it's considered affordable under this law. But for a person that's making $50,000, where are you in the FPL level? So 50,000, we'll go with a family of 4. You're just over 200%. And so at the 200% level, for a family of 4, it was $242 per month. So even though your employer offers coverage for $399, it's affordable according to the way the law is set up. So you would not be eligible for the subsidy through the individual exchange, in which you would get coverage for $242. So I think that's what it's referring to. Again, I'm not going to make an editorial of what's affordable and what's not, but that's how it works.
It covers, but doesn't that cover just the employee? What if you want to buy from that insurance company that your employer has, you want to buy family coverage,
Yeah, it is just the employee.
It's just the employee. And it's very expensive to get the family coverage.
The question is about if you're covered by your employer, but you want the family coverage under the employer's contract, under their policy.
And that is not covered under that figure.
Yeah, so I made it a little more simple than what it really is. It's just talking about the individual's piece of that. It does become more expensive when you're talking about the dependents.
So what that's asking is what happens to those dependents, those families who fall in that area where they're not eligible for the subsidy or the Medicaid.
I thought it defaulted back to that 9.5%.
The boosts are way up.
I'd like to point out when I started this, I said I was a government bureaucrat in the state of Nevada. Implementing this, I don't have the editorial on it.
So, I'm sure we have a good answer.
There are a couple of things, and correct me if I'm wrong, both of you, that one of the provisions in the bill is that if that $50,000 employee can find a cheaper insurance for themselves that is equivalent, they have the option under certain criteria, and I can't remember exactly what the criteria, they have the option of using that same money that their employer would have spent and buying that other insurance. You know what I'm saying? So you covered it. The other thing is that for children under 18, now you're probably talking about the 18 to 26s or somebody, or the other dependent. Children under 18, the criteria to be included under the children's health insurance is higher. So those kids, so a family may actually end up with two kinds of insurance depending on the ages within the family.
Will there be restrictions on which providers are covered under health plans in the exchange? So, for instance, will they cover services at public health departments? So I guess this question is, what qualifications, what restrictions, what requirements with insurance companies have to have in order to be in the exchange?
No,
basically?
let me answer my interpretation. The question is twofold. For Medicare, it has to be a Medicare physician who accepts assignment, which means that they agree that they will accept Medicare's rate as full reimbursement. And there are a number of physicians in our community who, for various reasons, choose not to accept assignment. They will still see you as a Medicare patient, but they don't accept assignment. So what this law asks is that these restrictions apply to who accepts assignment. The other is that, and I think John will back me up, is that insurance companies will contract with a physician through a network. So if I choose to belong to the St. Mary's Healthcare Network, then I would, and that network in turn contracts under the exchange, I would be under there. But if I choose as a physician not to contract with those networks, then I'm not in the exchange. Fairly.
Well, I have a question about providers.
Well, I work with the public health department here in Carson, and what I was referring to is oftentimes we are denied health insurance doesn't want to cover us because we have nurse practitioners rather than physicians on site 24.
And for all public health agencies as well as FQHCs, they have really the option of participating, but they all will, because the mission of a public health department is to serve the people within their community. And so once they become contracted, so to speak, then yes, everybody will be able to go to those places if they want. The other part of it, though, beyond any willing provider, is a caveat that within this legislation, there is strong encouragement for people to choose what the current term is a medical home. They want you to have one person or one group of people who is very familiar with you medically, I can yell really loud, who is very familiar with you medically so that they can help you manage all your problems. And that may be the public health department, it may be your internist down the street, but what they don't want to do, and what no physician wants to see, is doctor shopping, where I do this, and I go here, and I go there, and I go somewhere else. That fragments care and definitely raises costs. So the concept of the medical home, no matter where, if it's at the public health department, at Sierra Family, or at Dr. Yamamoto's office, that's where you start your medical care.
Okay, this one's on the, explaining the tax credits and changes in income tax deductions. And will CPAs be accountable for determining eligibility for the IRS? So I guess this is back to exactly how this all comes out here. Tax return.
CPAs are never accountable. If you sign your return, it's your turn.
But this will be, this all will be on the tax form.
Yeah.
Reporting, that's where you'll be reporting.
But why would it fall on a tax expert or an accountant rather than?
Right, I think that's the answer on that, but I'm just.
We didn't hear what he said.
What did he
say?
Microphone.
Steve say?
Gotta have the microphone.
I'm sorry.
Very still the mic again. I think that just like any other, anytime anyone sends taxes, it shouldn't fall on someone from the IRS or an accountant or a consultant or a tax advisor or anybody. It's always going to fall on the individual in that instance.
I think part of the question is the,
Microphone.
as I recall, the question had something to do with, are there going to be changes in income tax deductions, as in is the percentage of the amount that you can deduct for your health care going to change?
I didn't see that in the law. Currently, you can deduct health care costs at 7%. Is there above 7% of your AGI, right? Adjusted gross income? 7.5%. I'm not an accountant. And I saw no provisions in the law that changed that. So if by chance, if you have the $100,000 income and you're spending more than, what is that, $7,500, then theoretically that's still deductible.
Okay, in what ways would adopting Medicaid expansion change health care for Nevadans? What are the costs and consequences of adopting or not adopting the expansion?
Come on.
Well, I think that, and I tried to use this in my presentation, in that the federal government is putting up a lot of the front-end costs for the first couple of years. 100% of the cost for 2013 and 2014. So for Nevada, again, I'm conjecturing, this is my opinion, I guess, that would be a good thing, that it would cost Nevada a penny. Then the years after that, the federal government picks up 90% of it. So instead of Nevada having to foot the bill for the additional Medicaid folks, the federal government is substantially saying, we're willing to put up a lot of money.
The corollary of that is that these are people who are going to need health care in one way or the other, so who pays for it? Does it come under the Medicaid rolls, or does that person show up in the ER at the end of their pregnancy because they didn't get prenatal care, and now they have to have a C-section, and are they going to be able to pay that? No, that goes back to so the theory, and because it hasn't been in practice yet, but it is borne out by some scientific evidence that if you have coverage for those basic sorts of things, you will not utilize higher levels or higher cost types of care as much. So I will speak to children. 25% of Nevada's children don't have any sort of health insurance. Do they still need shots? Yes. Do they still need checkups? Yes. Do they still get ear infections? Yes. No matter if they're insured or not. So these are costs that are going to happen. If we expand Medicare to Medicaid, I misspoke, Medicaid, to those, theoretically, they will be able to access care in a more affordable manner, personally.
What does the act do as far as chronic diseases such as Alzheimer's, Parkinson's? Does it provide access to specialists?
The act itself does not specify what kind of care or who you see. That's basically up to the insurance plan that you choose, or for example, under Medicare, a specialist can choose to participate in Medicare or cannot, or to choose not to. So if you have a family member with Alzheimer's disease and you want that person to see neurologist A, if neurologist A is on Medicare and accept the patient to be seen, it's covered. If neurologist B is who you want them to see, but they're not on Medicare, there's nothing that I see in the law that says that neurologist has to accept that Medicare.
What happens to Medicare Part C, the Advantage program? You know what happens to that? Supplemental, is that, I don't know. Medicare Part C. That's the advanced plan. Advantage plan. Advantage plan.
And actually, from what I understand, Medicare Advantage is strengthened somewhat. It costs the federal government, on average, about $1,000 more per participant for the benefits that are included in Medicare Advantage plans. Having said that, Medicare Advantage plans have been great for the participant and they've been lousy for the providers, which is why, if any of you have looked for somebody who participates in Medicare Advantage in Carson City, you haven't found any. So the way I look at this law, it tries to decrease the gap in the sense. Medicare Advantage offers a wider range of services than the current Medicare, closer to what I listed as the preventative services, but not even that many. And so if standard Medicare starts covering these preventative services, that gap between Medicare Advantage and standard Medicare should close.
Just one more thing to add to that is that since the law is passed, we have more people enrolling in that. The costs have gone down.
So there's 8. Are we planning another one of these?
Yes.
Address more questions. I think my favorite rap is planning to continue not only on the Affordable Care Act, but other topics that be good to discuss to get answers. Because there is a lot of information to cover, and we've covered a lot of ground tonight. So, I'm sorry. So, should we wrap it up for this evening?
You know, I saw a lot of cards being handed in, so I think we have a responsibility to get an answer for those, because we really want to appreciate the fact we came here tonight to that time. So we are going to address everything was sent to us on a card. We're going to figure it out, and then it's just to figure out a way to answer back to you. So how do we do that? I think you have our email address. We're going to put together these questions. We'll do our best to get answers from you, either from our speakers here, or if they don't have the answer, again, somebody who can put it together for you. If you email us, you've got it in the program there, we will attach those answers and get them back to you. So does that sound reasonable? If we can't get you an answer, we'll be honest about that and say it. Does that work? Yes, we have copies of all the slide presentations. Jeff, you got them?
I will after the meeting, yes.
Okay, great. Again, if you email us and you'd like a copy of one or all three, we'll get them to you. We'll email right back to you. Does that make sense?
Yes.
Okay, great. What else can we do for you to help wrap up information tonight that maybe we didn't get to for you? Margaret?
Is this good for us or bad for us?
Is this going to be good for us or bad for us to stay in Nevada? Because a lot of people here aren't insured at all. And I'm just wondering if it's going to help, if it helps us and helps the doctors, and we have a beautiful hospital, we have to pay for it. Is that all going to be helpful, or are we going to just kind of have to close everything?
I'll put my personal opinion. I will tell you as a public health professional and seeing what lousy care we take of ourselves in this state, that I think that it will be good. Will it be perfect? No. But if it gives more people access to appropriate and timely health care, I think that's good.
Subject to whatever the czar decides.
What about the SARS?
There's a czar in there that has complete autonomy over this. Change rules of the book.
This council is composed of 8 heads of federal government.
They'll all answer to the czar.
Who's the czar?
I read it.
Respectfully disagree.
The czar. We'll read the healthcare bill.
She's the czar. Yes, even the microphone.
Okay, I want to state budget. That was impressive a little bit there, but I think there's a lot of people in the audience here that would like to answer the impact of both the federal and state.
Okay, well, how about you email that in, and we'll get some answers to it, because I'm going to wrap this up for this evening. I appreciate you all coming.